I was presenting on, how investing in population-based cancer registries and hospital cancer registries can provide important information that can be used to monitor and evaluate cancer control programs and cancer preventive as well as early detection and treatment interventions. So I was showing some examples from different parts of the world where population-based cancer registries exist, hospital registries exist, and how they provide data to evaluate what is going on in their populations. So I was showing, for example, in Kuwait, in successive cohorts of women, the breast cancer risk has substantially increased. In fact, compared to 30 years back, Kuwait has now almost threefold increase in breast cancer. And many low and middle income countries have something like 1 to 5% annual percentage change increase in breast cancer incidence. This comes basically from population-based cancer registry data. And I was also showing how the registry data can be used to evaluate how people survive after cancer treatment, which is an indication of the efficiency of the health services. And I was showing that people with very early stages of cancer, for example, breast cancer, have a survival rate approaching 90% in developed health services like in Turkey or in Singapore. As compared to that, in moderately developed health services like in India or in Philippines or in Thailand, the 5-year survival of a stage 1 breast cancer is around 70-75%, which reflects the efficiency of the health services. Okay, and similarly, this you can demonstrate for many other cancers as well, where treatment is very effective. And I was also showing in the Gambia, where cancer treatment facilities do not exist, 5-year survival from any breast cancer is less than 10%. So I was showing some examples, how population-based registries can be used to evaluate cancer preventive, early detection and treatment interventions. Take the African region. There are long-standing registries in Kyodondo County in Uganda and Harare in Zimbabwe. They have shown the evolution of the Kaposi sarcoma. The Kaposi sarcoma is a HIV AIDS-associated cancer, and it was very low, before the HIV epidemic evolved in East Africa. And from 1991, it increased so rapidly. Kaposi sarcoma incidence increased very rapidly, reached a peak around after 7 or 8 years, and became the number 1 cancer among men and the number 3 cancer among women. And then these countries introduced HIV infection control measures, education, improved access to antiretroviral therapy and things like that. And the Kaposi sarcoma incidence, as rapidly it climbed, it went down as rapidly. So the existence of the registries in Uganda, in Kyodondo County, which also encompasses Kampala, as well as in Harare, clearly showed how the Kaposi sarcoma epidemic evolved along with HIV epidemic, and then how the Kaposi sarcoma epidemic was controlled and was coming down with the coming down of the stabilization and decline in HIV infection epidemic with the introduction of antiretroviral therapies and education.